Okay, great. Well, welcome. I am excited to kick off another session, webinar, workshop, seminar, another episode, if you will, of Ask the Doc. And this week we're focusing on knee pain. We've had a number of questions come in and a lot of interest in our webinars. And so today I'm going to introduce my speaker in a moment. My name is Steve Sargent, the host. We're going to be doing more of these bi-weekly, so check back for other great topics that are focused on orthopedic pain and really innovative treatments, mostly non-surgical, as well as potentially minimally invasive surgical treatments available for complex orthopedic conditions. So today we're with Dr. Joe Mejia. And so a little bit about Joe, and I'll jump in and ask him some questions, but he's been with Performance Rehabilitation and Regenerative Medicine for a little over 10 years now. And so we'll jump into that. Joe, but tell us a little bit about yourself and maybe a little bit about your training. I know you're triple board certified, touch on that a little bit, and yeah, just some of your specialties.
Sure. Thanks for the introduction, Steve. So my name is Joe Mejia. As you mentioned, I'm medical director here at Performance Rehabilitation. I'm actually originally from West Virginia, Midwest guy. So my parents actually immigrated here from the Philippines in the 70s. They were recruited here. They were in medicine as well, to practice medicine in rural areas of the US. So they moved to West Virginia, did their training there, and me, my brother and sister were all raised in West Virginia. Wow. Went to University of Michigan for undergrad, and I met my now wife there. She's originally from Long Island, so that's how I ended up in this tri-state area. After University of Michigan undergrad, went to West Virginia School of Osteopathic Medicine, went back home, did my training there, and then applied for physical medicine and rehabilitation residency, which is basically non-surgical orthopedic medicine. Did that at NYU, Rusk Institute, and then a fellowship in interventional pain management at Rutgers, New Jersey Medical School in Newark. And that's where I did specifically pain management training, learning different type of injection techniques under guidance. So that's where kind of really we honed our skills for what kind of our specialty is now. So as you mentioned, I'm triple board certified, physical medicine, rehabilitation, sports medicine, as well as pain medicine, and been in practice over 11 years now.
That's awesome. That's awesome. So you've seen a lot. I mean, you see a lot of different conditions, complex conditions, both extremity as well as spine. I know that you've got incredible depth of experience with the spine, spinal injections, even regenerative medicine to the spine. That's not what this particular workshop is about, but we'll maybe come back to that because it's so innovative and you're so knowledgeable and experienced in that area. But honing in on knee pain a bit, I mean, how did you really kind of get all of your experience and kind of become, seen as just really a specialist when it comes to knee pain?
Yeah, that's a good question. I mean, basically, the reason that drew me into interventional pain management in the beginning is that I wanted to be able to do more than just, medications or, prescribing therapy. I wanted to be able to do some type of intervention to help patients in addition to that. And, corticosteroids have been around for many years and have helped a lot of patients, but the effects are often short-lived. So one of the areas that has been kind of definitely an area of interest in our specialty is regenerative medicine. And over the past, I would say 8 to 9 years, has really picked up some steam, and I've been doing it for about that time. Started out with things like platelet-rich plasma, started doing stem cells as well, but really have found an interest in regenerative medicine as a way to, help further improve patients' function and return them to their previous levels.
Yeah, awesome. So over the years, I mean, I guess, gosh, you've been doing regenerative medicine for about 8 years now, 7, 8 years, maybe more. And so saw a lot of knee conditions over those years, right? Primarily, I mean, I know a lot of knee, shoulder, hip, and certainly spine, but I know that you do thousands of knee procedures a year, and that's incredible. And so I want to dig into that a little bit deeper. Maybe tell us a little bit. I mean, you've seen a lot. What are some of the most common conditions you see with the knee?
Yeah, one of the most common conditions we see really is just wear and tear of the knee or osteoarthritis. Very, very common diagnosis. And that has to do with the way that our bodies are designed and how we use them. You know, that the knees are weight-bearing joints and they get used every day and are just subject to degeneration. Degeneration is a normal process. Unfortunately, as we age, there's going to be some degeneration of the cartilage that kind of pads the bones within the knee. But over time, it really can wear down. So we often will see that kind of gradual onset of pain and stiffness in patients in their knees. And, you know, we obviously do a history, physical examination, and diagnostic testing, but that is probably the most common knee diagnosis that we see is just osteoarthritis. Some of the other kind of more common ones, there's things like patellofemoral syndrome. If patients have pain primarily in the front of their knee, that can often be due to a little bit of laxity or looseness of the kneecap within the groove that it sits in. Also very common. So yeah, I'd say those are the two most common. And then of course, you know, if it's more acute pain, it could be due to some type of trauma like a meniscus tear, ACL tear, and things like that. We do see those, but that's just less often compared to the wear and tear type of conditions.
Sure. Yep. That makes sense. So we got some questions from our audience, so to speak, in advance, and I just wanted to kind of touch on a couple of those before we get into some of the treatments that are available to people for various conditions. But one was just interesting, and I hear this all the time. The question simply was, why does my knee click? What's your insight into that?
A very common question, actually. And the knee clicks actually because of little air bubbles. You know, there's nitrogen and other gases that get caught in any joint, really. And you can hear an audible pop or a click. In and of itself, typically that's not a big deal. If it's not associated with pain, it just clicks. That's okay. And it can be one early sign of osteoarthritis. On physical examination, we often look for something called crepitus or crackling within the knee. You know, when you examine the knee and bend it and it is cracking, that's one sign of wear and tear. So yeah, it's typically a benign type of thing that can be an early sign of some degenerative changes there. We obviously would be more concerned if the clicking was associated with acute pain and swelling. That would obviously indicate something much different, such as a ACL or meniscus tear that may actually bleed, and there can be some swelling or bleeding within the joint space after an acute audible pop. So that would be obviously more concerning.
Great. Comforting to a lot of folks, I'm sure, to hear that. And maybe not so much to some others, but it like you said, very common question. The other question that I hear a lot is related to, quote, bone on bone pain or bone on bone conditions, bone on bone contact. You even started to allude to that a little bit earlier with, the wear and tear, the osteoarthritis and the wearing down of cartilage. I often hear from folks that, they suffer from bone on bone contact. And, from my limited understanding, it is that is actually a fairly rare condition to truly be bone on bone. Can you speak a little bit to that? Just even the diagnoses that people are getting, how that comes up, what the condition really is or could be, and then we could start talking about some treatments.
Sure. Yes, a very common way to describe osteoarthritis or degenerative changes. When you look at an X-ray and there's narrowing of the joint space, it can be so narrowed that it appears that it's bone on bone. I would say that's probably pretty rare that all of the cartilage has really worn thin. But yes, without a doubt, sometimes it does wear thin. And it depends on sometimes too, there's three main compartments of the knee. I'll just bring a model since I have it on my desk here. The medial compartment on the inside, lateral on the outside. And this particular model doesn't have it, but there's a kneecap, which is the anterior. So you can have degeneration of one or all of them. And if there's bone on bone, obviously involving more than just one compartment, that is a more serious type of diagnosis. But the interesting thing is that even if patients come with severe degenerative changes, that does not mean that they're automatically a candidate for total knee replacement. We've treated a lot of patients in the past with, so to speak, bone on bone osteoarthritis, and they've done very well with a combination of physical therapy, injection-based treatments such as viscosupplementations, maybe corticosteroids to calm the pain down and the swelling down, and even regenerative medicine or genicular nerve blocks or radiofrequency ablation. These are ways to help control the pain, and they're considered non-surgical treatments. So yes, bone on bone does kind of indicate that there's more advanced osteoarthritis, but typically there is some cartilage, and patients may respond still to conservative management, even though they have advanced osteoarthritis.
Yeah, fantastic. That was very helpful. Thank you for laying that out. You mentioned a number of treatments in there, one in particular, viscosupplementation. That's got some different terms. People call it different things, right? Gel cushioning, injections, they even call it by a particular brand name, or referred to HA injections. To touch on that a little bit, kind of how you approach it and what the process is.
Sure it is. Rooster comb, it's often referred to as. So viscosupplementation or hyaluronic acid or HA, all indicate the same thing. Basically, to make it simple, these are ways to supplement the natural cushioning that's within the knee. Over time, unfortunately, that does tend to get used up and dried up, and you're essentially supplementing it. You're adding to that natural viscous cushioning and lubrication fluid that's found within the knee. There are, as you mentioned, a lot of different brand names out now, and certain insurance companies may prefer one versus another, but definitely a very common initial treatment for osteoarthritis to add that layer of cushioning in between the bones to help lubricate the movement, essentially. Very successful overall, patients, and very benign, actually, very easy to perform. And we've seen a lot of patients do very well with that in terms of their mobility, reduction of pain, and overall just improvement in quality of life. But definitely a step that you would want to try in the treatment algorithm for osteoarthritis.
Yeah, it's helpful. Before we get to regenerative medicine, one other question that came up was, can MLS help my knee pain? MLS refers to a robotic laser, cold laser, that's used at Performance. Can you touch on that a little bit?
Sure. Yes, within physical therapy, one of the modalities that is commonly used is MLS laser. That stands for multi-wave locked system laser therapy. And it's differentiated from different lasers that have been used in the past. And they're called class 4 lasers. And it just has to do with the wavelength, essentially, and the types of wavelengths that they use for this type of treatment. The main advantage of this particular type of laser therapy is that its anti-inflammatory effect, as well as its analgesic effect, without giving heat actually to the skin and other structures around there. It kind of deeply penetrates, so it can provide that. that therapeutic aspect. So in combination with, a comprehensive treatment plan, as we talked about, physical therapy to strengthen and stabilize the muscles around the knee, maybe injection-based treatments like viscosupplementation, MLS laser to help with the edema and the healing. Often it goes hand in hand with a comprehensive treatment approach for knee osteoarthritis in this particular case.
Mm. Yeah, incredible. I know that lasers had tremendous effects for many, and there's been some incredible healing, even in just a short period of time. People tend to see a difference due to that dual wavelength, the topical as well as that penetrating wavelength that regenerates at a molecular level, which is incredible. Let's turn our attention quickly to regenerative medicine. I want to be sensitive to your time and as well as the viewers. Oftentimes we'll get inquiries for, stem cell, right? I need stem cell of the knee. I'd like to get stem cell. I'd like to get stem cell. And we certainly do a lot of regenerative procedures, but who's appropriate? I mean, what conditions are appropriate for, stem cell or PRP, and then, what's the process?
Sure. Yeah, it involves a comprehensive evaluation of the patient and the situation. Depends on the main diagnosis. Since we were talking mostly about osteoarthritis, that is definitely an indication for regenerative medicine. Stem cells, platelet-rich plasma can help to promote healing and regeneration of the cartilage in there, which is the cushioning. Is it going to replace it or regenerate it to a 20-year-old knee? Probably not. I mean, this is, there is still some wear and tear, but definitely can make the cells that are there healthier. Often in the diagnostic process, we may get an MRI. We often will start with X-ray and diagnostic ultrasound to take a look at the bone and the surrounding soft tissue, but an MRI can give us a deeper look into structures such as the meniscus, some of the structures around the knee as well, such as the tendons and other ligaments, are often areas that may have partial tearing and may be a source of the pain. And if that's the case, things like partial tearing of a meniscus is a very amenable pathology, so to speak, to regenerative medicine, because basically what you're doing is promoting the body's innate ability to heal. The stem cells are naturally found in your body, as well as platelet-rich plasma, and we're essentially harnessing that capability in the body and placing it to an area where it may not get readily because of a poor blood supply to that particular part of the knee. For example, on the inside of the meniscus, if there's a tear there, there's not a great blood supply to that area. So by taking these healing cells that are naturally found within the body and concentrating them to the area of pathology, patients often will do well because it really promotes a healing process where those cells really can't get normally.
Yeah, thank you. Thank you for that. One thing, as you were talking about concentrating the injection, it reminded me that the vast majority, if not all of your injections and the injections done at Performance are guided injections, which my understanding is not incredibly common in the orthopedic world. Talk to me a little bit about that as we wrap up. What do you use and what's the thinking behind that?
Sure. Yeah, it's interesting how much medicine changes. And, I don't think I've been in medicine that long, but I've seen a lot of changes. I mean, I've been in clinical practice now 11 years. And of course, the training obviously is much longer. But when I first started my residency, everything was based on landmarks, the so to speak blind technique, where you're not visualizing where you're going, and you're based on palpation and feeling the area, knowing the anatomy, and injecting medication into a specific spot, which is good, and most patients will get response, but with technology these days and the availability, there's just a lot of other options. And as that becomes more and more available, it does take a little bit extra time, but why not do that to get 100% certainty and confidence that you're placing the medication in the correct structure and minimizing the discomfort for the patient, because there's no kind of fishing around. Essentially, you know exactly where the problem area is, and you can very specifically direct it. So the two modalities that we typically use are ultrasound or fluoroscopy, or it's basically a mobile X-ray machine. But both of those give us an extreme amount of precision on where we're placing the medication. It can identify readily if there's an effusion or swelling within the joint, because when you are injecting, whether it's viscose supplementation, corticosteroids, or regenerative medicine, typically you want to get rid of that extra fluid, that inflammatory type of fluid, before you would inject. Otherwise, it would dilute out whatever you're injecting. So between fluoroscopy and ultrasound, yes, our preference is really to do it under image guidance for that reason, for safety and for patients' comfort.
Yeah, I can't imagine another way as a patient, but it's fascinating. Well, Dr. Mejia, listen, thank you. I appreciate it. Like I said, I want to value your time and our viewers. To our viewers, check back. There's a lot more to talk about, other extremities, other conditions, and the spine as well. So there will be more. We will circle back, and feel free to go to our website, send us a message through the website, or to info@performancerehabnj.com, or even leave a comment on the Facebook page with your questions, so that we can make sure that this time is targeted and helpful to you and to our patient base or potential patients. So thank you, Dr. Mejia. Thank you to our viewers, and have a great weekend.